Thanks so much, Steve. Welcome everyone to the webinar today, Caregiving for People Living with Non-Alzheimer's Dementia. We're pleased to have you all in attendance. Before we start, Erin Long of the Administration for Community Living will provide a brief welcome. Erin?
Hello everyone. I'm happy to welcome you on behalf of the Administration for Community Living. I'd like to take this moment to thank Sharon Denny from the Association for Frontotemporal Degeneration and Angela Taylor from the Lewy Body Dementia Association, as well as Sarah Schumann from RTI International for presenting with us today and educating us on caregiving for people with non-Alzheimer's dementia. With that, I'll send it back to you, Sari, so we can get started right away.
Thanks so much. So as you heard, my name is Sari Schumann. I'll be moderating and presenting at this session today. Our speakers with me today include Angela Taylor and Sharon Denny. Angela Taylor is the Senior Director of Research and Advocacy for the Lewy Body Dementia Association, where she leads research, advocacy, and educational activities of the organization. Her personal experience as a Lewy Body dementia caregiver and 15 years of service at the Lewy Body Dementia Association make her a regularly invited speaker at scientific and educational conferences on the impact of Lewy Body dementia on those diagnosed and their family caregivers. Sharon Denny is Senior Director of Programs at the Association for Frontotemporal Degeneration, where she leads strategic development of support and education for people with frontotemporal degeneration, their families, and healthcare professionals. As an advocate for high-quality and responsive services, she has promoted inclusion of people living with frontotemporal degeneration, built a national network of AFTD-affiliated support groups, and directed professional educational initiatives. You'll first hear from me today about dementia in general, and I'll give you some information about vascular dementia. Then we'll hear from Angela Taylor about Lewy body dementia, and finally from Sharon Denny about frontotemporal degeneration. We'll reserve the end of the session for questions and answers. I'd like to start my presentation today by talking about some basic definitions and information about the various types of dementia. Although many people consider Alzheimer's disease and dementia to be the same thing, there are actually several diseases and disorders that can cause dementia. We'll take a look today at the three most common forms of dementia after Alzheimer's disease, which include vascular dementia, Lewy body dementia, and frontotemporal degeneration. The National Institute on Aging defines dementia as the loss of cognitive functioning, including thinking, remembering, and reasoning, and behavioral abilities to such an extent that it interferes with a person's daily life and activities. Most causes of dementia are progressive, where initially the impact on functioning may be mild, but in the end stages, the person living with dementia may be completely dependent on others for activities of daily living, such as eating and bathing. Often people think of memory loss as the main symptom of dementia. For people with Alzheimer's disease, memory loss is the most common early symptom. But with other forms of dementia, the disease may start out very differently, with changes in personality or motor skills, possibly hallucinations. This slide shows you the many areas of functioning that may be impacted by dementia, including concentration, the ability to speak, read, and understand language, emotions, and motor skills related to walking, eating, bathing, and dressing, just to give a few examples. As we know, Alzheimer's disease is the most well-known cause of dementia. We don't have perfect data on the prevalence of each type, but it's estimated that Alzheimer's disease makes up about 60 to 80% of all cases of dementia, with nearly 6 million people in the United States currently affected. Vascular dementia is also common and often occurs along with Alzheimer's disease, but it is caused by damage from a stroke or other vascular issue in the brain. Lewy body dementia makes up about 20% of all cases of dementia. Early cognitive symptoms are more likely to include challenges with problem solving or attention rather than memory. Angela Taylor will provide you with much more information on this form of dementia and how it impacts people with the disease and their families. Frontotemporal degeneration is less common than vascular dementia or Lewy body dementia. There are only about 50,000 to 60,000 cases in the United States. This form of dementia tends to have a much earlier onset of symptoms. There are different variations of frontotemporal degeneration, which Sharon Denny will describe to you in more detail. Again, with frontotemporal degeneration, memory problems are not necessarily the initial symptom. So I've mentioned some of this information in the prior slide, but I want to highlight some of the ways that different forms of dementia can present differently, which impacts the experience of the person living with disease and their family members. Early symptoms of dementia can vary from one form to another, and depending on the specific cause, early symptoms may include changes in attention, behavior, motor skills, sleep disturbances, or visual perceptions rather than memory problems. The ways each of these diseases progresses also can differ. For example, vascular dementia may progress more slowly than Alzheimer's disease, and the order in which different cognitive functions are impacted also differs significantly from one form of dementia to another. Sharon will talk more in depth about issues related to the age of onset, and will address how a diagnosis around age 40 or 50 is entirely different than being diagnosed later in life in terms of family, finances, social support, insurance options, and a whole range of other issues. These different forms of dementia tend to be accompanied by different types of co-occurring conditions. People with vascular dementia often have other cardiovascular conditions such as heart disease, diabetes, and high blood pressure that require considerable medical management. People with Lewy body dementia often have specific physical changes and need more help with daily activities like eating and bathing, even early in the disease. These different presentations of dementia therefore can create very different experiences for the people affected. There's been much less research on non-Alzheimer's dementias compared to Alzheimer's disease, and many medical professionals lack the basic knowledge which can make the experience for people with these other forms of dementia challenging in a number of ways. They're more likely than people with Alzheimer's disease to be misdiagnosed or to have seen numerous providers before obtaining a diagnosis. Even after diagnosis, it can be challenging to find healthcare providers who are knowledgeable about the latest research and best treatment protocols. Families often lack the basic information about symptoms or what to expect over the course of the disease and how to support their loved ones. This general lack of awareness about these other forms of dementia can contribute to feeling isolated among the people who are impacted. So I'll just get into a little more detail on the vascular dementia and then we'll move on to Angela and Sharon's presentations. So vascular dementia, as I mentioned earlier, affects about the same number of people as Lewy body dementia, but only about 10 to 15% of dementias are estimated to be vascular in nature only, since vascular dementia is commonly found in conjunction with Alzheimer's disease. This type of dementia develops when there's some kind of vascular damage in the brain and is often caused by one or more strokes. Sometimes strokes are too minor to even be noted on their own, but are significant enough to create lasting damage which can become worse over time as more strokes may occur. Not all people who have a stroke, though, will develop dementia, but it does impact about 1/4 to 1/3 of people who have a stroke. Of the three types of dementia we're discussing today, vascular dementia is the one that most resembles Alzheimer's disease in terms of symptoms and progression. The same types of factors that put people at risk for cardiovascular problems such as diabetes, high blood pressure, and smoking also are risk factors for vascular dementia. The symptoms of vascular disease are often similar to those of Alzheimer's disease, but will depend on what part of the brain's been damaged by the stroke or other vascular event. Symptoms may come on suddenly after a stroke, or they may be more gradual if there are frequent and smaller strokes over time. So despite how common vascular dementia is, there's not a lot known about how the experience of caring for someone with vascular dementia may be different from Alzheimer's disease. We do know people with vascular dementia often have coexisting medical conditions, and that coordination of medical care that this involves may mean greater reliance on caregivers and require coordination with multiple healthcare providers. Research on whether the burden these caregivers feel is greater than, if it's greater than Alzheimer's disease, is mixed. So we don't know a lot about the specific supports and services needed for this group of caregivers and whether those needs may differ in a significant way from caregivers of people living with Alzheimer's dementia. So I'm going to turn things over to Angela now to give us more information about Lewy body dementia.
Okay, thanks, Sarah. I really appreciate the opportunity to be here today and talk about LBD. All right. So Lewy body dementia is a common form of dementia, but as Sarah indicated, it's not as well known to the general public. It affects far more than just cognition. It affects behavior and mood, but also a person's ability to move normally, their sleep patterns, and it can disrupt the functioning of their autonomic nervous system. While Alzheimer's disease was described in the early 1900s, Lewy body dementia wasn't described in the literature until the 1980s, and so this disease is really decades behind Alzheimer's disease in research. So it stands to reason that the public and even a lot of healthcare professionals are not as familiar with it as we'd like them to be. It was first, the diagnostic criteria was first defined in 1996. So really we're only talking about the last 13 years that people have been diagnosed the same way internationally. So we use the term LBD, or Lewy body dementia, as an umbrella term because it relates to any dementia syndrome that's associated with the presence of Lewy bodies in the brain, and I'll explain those in a minute. So there's two conditions that fall under the umbrella. One is called dementia with Lewy bodies, and the other is Parkinson's disease dementia. And we'll go into detail about those shortly. LBD is the second most common form of progressive dementia after Alzheimer's, but it is the #1 most misdiagnosed form of dementia. And depending upon how the symptoms present, it's either diagnosed initially as Alzheimer's disease, Parkinson's disease, or a psychiatric disorder. Those are the most common initial diagnoses. This form of dementia is associated with the presence of some abnormal protein deposits in the brain. This protein is called alpha-synuclein, but when it misfolds, it's been called Lewy body, and that's after Dr. Friedrich Lewy, who was a neurologist who first identified these in the brain of a woman who died with Parkinson's disease. And so it was originally associated with a motor disorder, and then decades later, it was associated with a form of dementia. So they're very closely related biologically, and you'll see there's quite a few overlapping symptoms as well. So we use the term Alzheimer's disease and Parkinson's disease, so why can't we call this Lewy body disease? Well, there's a lot of disorders that kind of have similar biology and symptom presentation, and so we have to be careful. Lewy body dementia refers to any form of dementia that's associated with Lewy bodies in the brain, and I mentioned dementia with Lewy bodies and Parkinson's disease dementia. But a Lewy body disorder is any medical disorder, including Parkinson's disease, where there is no dementia present. Also, it includes another condition called multiple system atrophy. Last but not least, we use the term Lewy body disease to talk about those misfolded protein deposits. And so that's the biology of the disease in the brain. It's really important for families to get an early, accurate diagnosis when somebody in their life has Lewy body dementia, because it affects not just the person with the disease, but also the primary caregiver. We know that people with Lewy body dementia are more responsive to the medications that were originally developed for Alzheimer's disease, and that's a class of drugs called cholinesterase inhibitors. And so they can truly benefit in a more substantial way from early intervention. On the flip side, we also have to be protective with a diagnosis, because it helps avoid certain medications that may have more severe side effects in people with LBD compared to people with Alzheimer's disease. Most importantly, and that certain kinds of antipsychotic medications. But it goes as far as even certain over-the-counter medications or anesthesia. So these early diagnoses can help protect people from getting medications unless it's absolutely essential. And last but not least, it allows us to provide greater education and support to the family caregivers and ensure that individuals with LBD and their family members get referred to services that will help them over the course of the disorder. So dementia with Lewy bodies, we'll speak specifically about this, is quite challenging to diagnose. I mentioned earlier that sometimes people get different diagnoses based on what the earliest symptoms of DLB occur. And so if a person starts mostly with cognitive symptoms, they might be diagnosed with Alzheimer's disease. But if they present instead with visual hallucinations and cognitive impairment, that might be diagnosed as a psychiatric disorder. But over time, a person with DLB will develop a whole cluster of symptoms that help doctors more clearly diagnose DLB. It also requires a specialist to diagnose, and sometimes people who have DLB may originally start with something called delirium, where they have a sudden change in cognitive function. So it often masquerades as something else. It's also challenging to treat, as I said, because of medication sensitivities, and there's really no FDA-approved medications for many of the symptoms of LBD, and so we have to use medications that were originally developed for other disorders. It's not on the public's radar, although we do see celebrity diagnoses and major news stories that are helping to bring this to the forefront, although we don't want anybody to be diagnosed. These are the stories that really grab the public's attention. Recently, Ted Turner came out and indicated he was living with Lewy body dementia. And of course, when Robin Williams passed away, later it was learned that he had Lewy body dementia as well. So we find that these families who are living with this disease struggle because nobody in their life knows about this disease, and many of their healthcare providers don't as well. So we have to find ourselves as family members as being really proactive advocates and even educators in places like emergency rooms, dentist offices, or anytime we have a loved one going into surgery. The most important takeaway from this particular slide, though, is that if somebody is in the hospital with LBD, it's really important that a neurologist be called to consult, because the treatment of their behavioral symptoms requires a very careful strategy. So I'm going to go into the symptoms now of the disorder and how we can adapt our lives and provide support to that person. So the cognitive symptoms of LBD and some differences from Alzheimer's disease. As Sari mentioned, it's not always forgetfulness, although people with LBD can be forgetful. More often, though, they're having problems with their executive function, problem solving, analytical thinking, or doing things in sequence. That's impaired very early, as is their ability to pay attention. And so that may mimic a memory problem. They actually don't take information in initially. They can also have a problem with the way they understand how things relate in three-dimensional space. That's called visual spatial problems, and their speech may also be altered. So for this, we really, cognitive symptoms are largely treated with some of these medications developed for Alzheimer's disease. People who are struggling with changes in their cognitive function may benefit from counseling or therapy so that they can learn to adapt and adjust emotionally to their diagnosis. But on the caregiving side, we have to adapt as well, and that's learning to slow down the pace of life, be flexible and adjust our own expectations, and also as caregivers, families need to learn how to accept help that they might not normally be seeking. Cognition in LBD fluctuates as well. That means from day to day or even hour to hour, a person may function differently. They may not have the same cognitive skills, and it can happen unpredictably. They can have sudden episodes of confusion or excessive daytime sleepiness. We have research shows that some people benefit from psychostimulants, and from a caregiving perspective, we have to be prepared that within a given day, we cannot predict what their cognitive abilities will be. We do have to build in a little extra time, certainly be patient as we work together with them. And because they may be struggling, they will tire out more easily. And so planning a nap within the day is also very helpful. People with LBD will have Parkinsonism or changes in movement that resemble Parkinson's disease. And that can look like muscle rigidity or stiffness, or a change in their gait where they have a shuffling walk. Balance problems or falls are common and often can be an indicator, even if you don't notice some of the other symptoms that are Parkinsonism, that we need to explore Parkinsonism. Tremor may be present, but is generally less pronounced than what's seen in Parkinson's disease. But you'll see that slowed movement and decreased facial expression. These are all very common. And what people are often surprised at is also the voice is affected. A person may have a softer or a more whispery or a hoarse-sounding voice. So for the Parkinsonism, medicine developed for Parkinson's disease, specifically carbidopa-levodopa, can be helpful, but it may also worsen or create or cause visual hallucinations, which is another LBD symptom. So that has to be reserved for when symptoms, the motor symptoms, are more significant. Physical therapy, OT, and speech, those are all very helpful add-on therapies to accommodate the changes in movement, and certainly an assessment of safety in the home environment is very important. The autonomic nervous system goes through some change as well, and that alters everything from a person's temperature regulation to their blood pressure and their digestion. So dizziness and fainting can occur due to blood pressure changes, excessive sweating or senses of cold for temperature regulation problems, but even early urinary incontinence. Or chronic constipation. These are common and part of life with LBD. And so we really encourage families to look at these other symptoms and be proactive and talk to the doctor about things like compression stockings or added salt, or ensure that they have adequate hydration if fainting is a problem. Dressing in layers will help address this temperature changes. A toileting schedule and medications or stool softeners can help with the constipation. And certainly if anything suddenly changes, that requires a call to the physician. Sleep disorders are common in LBD as well, specifically one called REM sleep behavior disorder, or RBD. And a person who has RBD will physically act out their dreams while they're asleep, where compared to people who don't have that disorder, we go to sleep and we dream and we are physically basically immobilized. And so they may hit or kick or yell in their sleep, and they may injure their bed partner. This can predate the onset of dementia by a year or even many years or even decades. So this is a big risk factor for LBD and Parkinson's disease. Insomnia, restless leg, some of these other sleep disorders are also common. They are treatable. Clonazepam or melatonin are used for REM sleep behavior disorder. But again, we want to assess the sleeping area for things that can improve safety. We need to balance out sleep during the day and naps with staying up long enough that they have a good night's sleep, and also regular sleep hygiene, things like eliminating caffeine after dinner. One of the more challenging problems families experience are changes in behavior and mood, and that's specifically visual hallucinations and delusions. These are very common. And in other disorders, other forms of dementia as well, you'll experience depression, apathy, anxiety, things like that. So we find that in LBD, the cholinesterase inhibitors, which are initially used for cognition, can also be part of a long-term strategy to treat behavioral changes in LBD. But from a care perspective, we have to learn to walk into their reality and accept that that's we're not going to be able to talk them into our reality. We have to accept where they are and respond to the emotions that they're expressing through their behavior, through their words. We can try redirecting their attention. These symptoms generally are not, they have an ongoing presence, but if they suddenly worsen, that's an indication that something else may be going on, like a urinary tract infection. So with LBD, we do have to look at safety across the board. Driving is one of those early issues that we have to look at, because a person with LBD not only has reduced attention and slowed thinking and changes in how they look at things in three-dimensional space, but also those visual hallucinations and slowed physical movements. And all of those can make driving unsafe. So caregivers have to really assess from their own judgment whether this is a risk that needs to be stopped. They have to have conversations with the provider, and that can be done in advance if they have safety concerns, but we really encourage family caregivers to trust their judgment and ask for help from the healthcare provider who can step in and really set a boundary that doesn't disrupt the caregiving relationship. Certainly there are alternatives to driving, friends, family, and senior transportation services, but this is an area that caregivers and people with LBD have to address early on in the disease. I want to wrap up just by talking about some unique implications for caregivers when we're talking about LBD. That includes early dependence in activities of daily living, especially in the areas of urinary incontinence. Their visual, spatial, and executive function may make it hard for them to plan and follow through on plans, and certainly that fluctuating cognition. So from early on in the disease, caregivers play a very significant role in helping people with LBD navigate their everyday life. Public awareness, as Sari mentioned, because there isn't a lot of it, there's a strong sense of isolation. We've got to be educators when we're often just adjusting to living with this disease, as well as passing along information to our primary care providers, hospitals, and other healthcare providers. Caregiver burden in LBD, there's been some initial research that suggests that people who are caring for somebody with LBD may experience moderate to severe caregiver burden. And so we've got to explore this a little bit further as well. In the end, as healthcare providers, you can really be a strong resource for families, help them learn about the symptoms and the treatments, empower them to advocate for the comprehensive and appropriate LBD care, make sure they're getting referrals to community-based services, help them find a community of support. Certainly LBDA has a lot of resources on our website. Facebook has a lot of support groups online, and certainly community-based support groups as well. Nobody needs to face this disorder alone any longer, and there's a lot of avenues for them to connect with others who are walking in their shoes. And certainly we encourage you to help them learn self-care and coping strategies, reminding them that they are as equally important as the person they are caring for. And so I'd like to leave you with my contact information. If you have any questions, look forward to hearing from you later.
So I'm Sharon Denny. I'm happy to jump in and follow Angela, who's laid such a nice foundation for us, along with Sari in the earlier conversations. And I'm very happy to be with you today to talk a little bit about frontotemporal degeneration. So as you've heard a little bit, the location of damage in the brain is really significant to the type of dementia that someone experiences, and especially the types of symptoms that people have. In FTD, there are three main clinical presentations. The damage is in the frontal and temporal lobes of the brain. So if you think of putting your hand on your forehead and then over your ears, those are the parts of the brain we're talking about. And these are the areas that control different types of cognitive and behavioral and emotional functions. So the three main presentations of FTD are behavioral variant FTD, primary progressive aphasia, and then some related movement disorders that on this slide are progressive supranuclear palsy and cortical basal syndrome. These we'll talk about a little bit more as we move ahead, but these are different symptoms. It's not primarily a memory disorder, as Sari said. And the clinical symptoms are definitely one of the things that distinguish FTD from some of the other types of dementia. The other, as was mentioned too, is the age of onset. So the average age of FTD onset is in the mid-50s. There's a very wide range possible. So there are some very unusual cases of people diagnosed in their 20s on up into the 80s. But if you think of this as a younger onset disorder typically, it is the most common form of dementia for people under the age of 60. And then the third factor that really characterizes FTD is the prevalence, which again, as has been mentioned, it is a less common form of dementia. And so there's about 20 cases per 100,000 people in the 45 to 64 age group, with an estimated prevalence of about 50 to 60,000 people in the U.S. This is a very soft estimate. There's still significant challenges in diagnosing FTD with confidence, and so many people believe this is an underestimate. But with the definition of a rare disease by the NIH and CDC that of 250,000 people affected or less, FTD does fall into that category of being considered a rare disease. This is kind of a busy slide, but what I wanted to do here is just underscore the idea that FTD is not one disease. It is actually a spectrum of different disorders that affect the same parts of the brain that we've identified. These different clinical subtypes are identified by the earliest symptoms that are identified and can be traced and are prominent in terms of what the experience of the disease is by the person who experiences them. What I want you to do is kind of focus on the 4 that are highlighted in the middle of this rainbow. So you'll see here behavioral variant FTD. This is the most common subtype of FTD, makes up about 60% of FTD cases. And this is a form that's characterized by damage in the frontal lobes. And so you do see the difficulty with executive functioning that Angela was describing with planning and organizing. There's also a decreased judgment, an ability to be self-aware, which contributes to poor decision-making, and disinhibited behavior, which is really characterized by sort of a lack of restraint over following social norms. People who have typically been very polite and functioning, adapting their functioning to the setting that they're in, lose that ability to show that restraint, and you see breaking through some inappropriate behaviors in ways that didn't happen before. There's also a significant loss of empathy and other social and emotional changes that go along with behavioral FTD. The next 3 to your right are all different types of primary progressive aphasia, and this is primarily a language disorder. And the different subtypes here indicate different specific impairment in language. So the semantic variant is when people have fluent speech, but that there's a decreased ability to recognize words, and there's a loss of meaning of those words for these individuals. Then non-fluent or agrammatic primary progressive aphasia is characterized by a halting speech or difficulty articulating. And people fall back on using shorter phrases, and they kind of lose the grammar of language that connects their sentences together. And then logopenic primary progressive aphasia is also a fluent, kind of expressive speech, but slow. And folks with logopenic PPA have trouble with word retrieval. And the other one I want to mention on this slide is actually all the way to the left, which is FTD with motor neuron disease. And in this case, there's a subtype of FTD where people experience both the cognitive and behavioral or language symptoms that fit the threshold for diagnosis in with FTD, but they also have in conjunction the muscle wasting and weakness that goes along with motor neuron disease. This particular subtype of FTD is actually contributing an awful lot to the research and the understanding of both FTD and ALS, especially over the last 10 years when we've recognized a continuum between these 2 diseases. So here what I just wanted to underscore is, there is a lot of heterogeneity in FTD, and the terminology can become particularly cumbersome and confusing at times. So the phrase frontotemporal lobar degeneration is the term that refers to the specific pathology that underlies these syndromes that we've been describing. And similarly to what Angela said, the pathology is a feature of clumped up proteins. So proteins that are normal, but they start to misfold when disease is present. So in the case of FTD, there's actually 2 main proteins that are involved in frontotemporal lobar degeneration. One is the protein tau, and one is TDP-43. And you'll see here that these are associated with different clinical syndromes. And so one of the challenges here is that the underlying pathology does not map specifically to one particular clinical presentation, adding to a layer of complexity. And in addition to that, there are some forms of primary progressive aphasia, especially the logopenic type, that can be related to Alzheimer's disease. So in addition to having a very complex clinical picture, you also have a very complex pathology that's underlying these particular types of dementia. And we'll add one more layer to that, which is that in the genetics of FTD, there's also some differences from Alzheimer's disease. So genetics plays a greater role in FTD than it does in Alzheimer's disease. About 50 to 60% of FTD cases are sporadic, where there's no apparent family history for the individual who's diagnosed with it. But we do have a larger number of people for whom it is familial. So up to about 40% or more of people may have a family history of FTD or another neurodegenerative disease that's evident in looking at their family pedigree. And in 15 to 20% of those cases, there is an autosomal dominant genetic mutation that can be tied to the cause of the disease for an individual and throughout a family. And when there is a mutation that's dominant in this fashion, it means that each offspring of someone with the mutation has a 50% chance of developing the disease. So this 15 to 20% of autosomal dominant FTD is significantly higher than in Alzheimer's disease, where I believe it's about 5% or less, where there is an inherited mutation contributing to the disease. So when you put all this together, what does it mean in terms of the experience for people who are living with FTD or for their care partners? And we've touched a little bit on the diverse clinical symptoms and the younger onset, and that it's less common. Diagnostic challenges we'll speak to a little bit more. The family and financial impact and the complex pathology and genetics. When you put all these things together, there is a demonstrably higher level of care burden or care needs for folks who are facing FTD. So FTD impacts the entire family system. As a younger onset disorder, and one that's hard to identify and characterize still, the impact is really higher across all of the relationships within the family. So misdiagnoses, the unfolding of FTD is particularly difficult. These symptoms are very gradual in their onset, so you will see folks with very gradually changing behaviors that are hard to identify, and where there's a trajectory that can be fairly long in terms of getting to a diagnosis. So the symptoms of changing behavior, changes in judgment, changing interpersonal relationships, the impact of that is that family and friends are seeing these behaviors, not understanding what's happening, and that they've been coping with the disease long before it's diagnosed and long before they really know or understand what it is that they're confronting. So people, as a result, begin to find other ways of explaining the changes that they see. They'll often believe that the person is stressed or depressed or anxious, and many of the misdiagnoses actually that are common are psychiatric disorders, and so people may be funneled into treatment for depression or anxiety, but over time realize that this isn't helpful, and now you've had a longer delay before being able to really understand the core of the behavior changes that are happening. So we know that on average it takes about 3.5 to 3.6 years for someone with an FTD to be accurately diagnosed. And again, that's a longer period of time than in Alzheimer's, where it's usually maybe 2.5 years or so. So people are coping with the symptoms of the disease and changes in behavior, which sometimes can include significant financial loss from bad decision-making in business or family finances, and then also broken relationships. So one of the things that we really stress is that recognizing the impact of this period of time before diagnosis is really critical both for providers and for care partners in terms of being able to develop a helping relationship and understanding just how stressful this period of time is for folks. And then the fact that the impact of the disease, the disease hits at an earlier stage of the development of a family, when people could have children at home, or their children, young adults who are emancipating from the family, and aging parents. And so the roles that each of these elements of the family play are changed significantly by the introduction of caregiving in the fashion that it happens. The isolation that Angela mentioned with LBD is also very common with FTD. Because, again, you have a situation where symptoms are not recognized as illness. They're not recognized as dementia. They're believed to either be psychiatric or other types of just bad behavior until a diagnosis can be achieved and an identity and sort of an understanding to the experience is offered. The behaviors that come along with disinhibited kinds of behavior can often be intrusive or embarrassing. They do sort of impact the relationships that people have, which causes social disruption in ways that some of the other types of dementia do not, which magnifies the isolation that people find. And I mentioned the complex financial and legal issues. Sometimes behaviors do show up even before diagnosis is made in terms of shoplifting or petty crimes that way, where people may be introduced to the legal system as a result of symptoms of the disease before that's been fully understood. And then the lack of awareness and the lack of specific understanding of how to provide services for folks with this cluster of symptoms in this particular neurodegenerative disease is also a burden for the families. And so all combined, we do see impact in different ways. I mentioned the financial impact, and this is a study that was published in 2017 that was based on a survey of 670 people, actually. So 670 caregivers completed a survey, which again, in a numbers game of a relatively rare disease, is a significant number of folks responding. And what we found was that the toll that FTD specifically takes, largely because of its younger onset, when people are at the peak of their career, the economic toll is significant. And in fact, for the 12 months before diagnosis, most families reported they had income in the $75,000 to $99,000 range, and that after diagnosis that fell as much as 50%. And when all the factors were taken into account, FTD on average costs the family about $120,000 a year, which is roughly twice that of the economic burden of Alzheimer's disease. And so we see especially the toll that having the younger onset takes, both economically and then in terms of the fabric of the family. So what can we do if we know that isolation and the care burden are higher? There's a couple of trends that I want to point out as kind of a fundamental aspect of this. One is that the focus on quality of life, of course, is critical. And in recent years, there has been a greater effort to really maximize the inclusion of the person with FTD. As diagnosis gradually becomes earlier, people are able to participate in care decisions and in planning in ways that they have not been able to if they're diagnosed later on. This is a prime mover for why earlier diagnosis is necessary, because in many, many cases, the person with the disease has almost been excluded from an active role in determining care and decision making, which in some cases not everybody is able to because of the impact of the disease. Some may have a greater impairment in their own judgment, but still being able to include folks with the disease along with family members, each to the point that they're able to be, is really important. And we also know that the best intervention in FTD still definitely is a well-informed, empowered person with the disease and care partner, and those become the goals of care from early on. So what can we do for education? The key here is to make sure that people have access to specific information about FTD so that they realize this is a different form of dementia that has distinct symptoms. Understanding that the symptoms people face are from the disease is also really critical. Many people think it's willful behavior and that the person could be behaving differently if they would only recognize what was wrong and act accordingly, which is really the definition of the disease. These are not symptoms that the person can control. And so having that understanding is really important in order for care planning to take place. This is not willful behavior, but is often confused for that. And then Alzheimer's disease approaches really aren't sufficient. So when people with FTD, if they have intact memory, the approaches that Alzheimer's disease relies on may not work for folks with the ability to remember and be resourceful and have different types of cognitive impairments. From the medication standpoint, Alzheimer's disease medications are not indicated in FTD. The proteins are different. So going back to the proteins that we've been mentioning for each of these disorders, Alzheimer's medications are often counterindicated in folks with FTD because, though, there's a chance that some of the underlying pathology is Alzheimer's disease. It's not inappropriate that a doctor carefully consider that as a brief trial. Again, the complexity makes it really difficult, but in most cases of FTD, Alzheimer's meds are not going to be helpful. Non-pharmacological interventions are really key. So having a productive daily routine, making sure to look at the simplifying and structuring the environment, and making sure that adequate supervision is available within a level of respect and dignity for the person and within the resources of the family is really important to be able to kind of shape the behaviors that might come along with the symptoms. Assessing for safety is critical. You know, declining judgment and lack of awareness are a bad combination for folks who have access to power tools or driving or guns and weapons. And so ensuring that the environment does not provide easy access to these things is a critical consideration at every step of planning for care. And as Angela mentioned earlier, advocating for services for folks who are not fitting into the regular aging services network is really important. And so the age of onset here is a real critical factor where people do need extra assistance from providers and extra consideration to try to access the benefits and the resources that they need because they are not automatically available. And so we're adding on additional layers of need on top of the caregiving that the families are already providing. And as I wind down, I want to make sure that people realize that there are now a growing array of FTD-specific supports available. And this is important because it's within these communities where people will find folks who really do understand the particular burden that comes along with the types of challenges that we've been identifying. So whether they're face-to-face groups, phone or online groups, there's a real effort within these communities to help reframe the experience of the guilt and the hurt that families face, to reframe the relationships, and then to be able to do some creative problem solving and figure out how to tailor general interventions for a particular person's need as best as possible. I want to mention just quickly the FTD Disorders Registry, which is a way for everyone to participate in research moving these diseases forward. This is a self-report registry that can be accessed online. It will also be an avenue through which people can access clinical trials as they come online for FTD. And so supporting families requires all of these different elements. From disease education to furthering research, and certainly the advocacy along the way is really critical here. Much like Angela mentioned, AFTD has a bunch of resources that are available for folks particularly interested in FTD, and I encourage you to access them through our website. And with that, I will move things back to Sari and for questions.
Sari, if you're there, we are not able to hear you. I don't know if perhaps you might be on mute.
Can you hear me now?
Ah, there you are.
Okay, not sure why that happened. So we'll move to questions now for the rest of our time together and for the next 10 minutes or so. And you can continue to put your questions into the question and answer pod of the webinar platform. And on the screen, you'll see contact information for the three of us if you would like to reach us for any purpose. So I wanted to start with a question that came in for both of you, Angela and Sharon, about addressing the issue of diagnosis and communication of that diagnosis from a physician to a person with Lewy body dementia or frontotemporal degeneration. Is there any support that you give on your websites about how physicians might do this? Are there suggestions that you might give the caregivers to encourage their physician to talk to the person they're caring for? If you could just address that in whatever way makes the most sense for the particular, for Lewy body or FTD.
This is Angela. I'll go ahead and jump in. I think there are research shows that there are a lot of people who report not being told they have a diagnosis. I'm not sure if that means they weren't told or they don't remember or they didn't understand their diagnosis, but certainly there's a very large proportion, somewhere around 50%, who don't recall being told that they've been diagnosed with a form of dementia. I think our stance is it's essential both for the person who is living with dementia and their family to know about the diagnosis. I think there's some hesitancy in delivering that information by some physicians because they don't feel like they have adequate tools yet to make a significant improvement in their quality of life. But I will tell you that within LBD, we certainly see that with comprehensive clinical treatment of all of the person's symptoms and adequate education and support for the caregiver. So from our perspective, I think it's an essential part of optimizing everybody's well-being after this condition has started.
I definitely would echo that. I think the real challenge that folks receiving an FTD diagnosis face is that we know that there's more people who are actually now perhaps making a diagnosis of FTD than know about resources to offer. So to the point that Angela said, where people feel there's not a lot they can offer, doctors should really know about our organization, should know where there is information that can be delivered to the family when the diagnosis is made, so that the focus is on quality of life and that there are things you can do to manage some of the symptoms, to shape some of the symptoms, and to continue to learn about the disease.
So I think everyone knows now from your slides, from both of your slides, where to find more information about the specific types of dementia. Do you have any suggestions for people on resources for finding practitioners who can accurately differentiate between the different types of dementia?
This is Angela. I can jump in with that again. The Lewy Body Dementia Association has formed our Research Centers of Excellence program. We have 25 leading academic sites across the country that we have identified that can provide expert differential diagnostic services. These are major academic research centers. So that's one thing. But many people don't have access to that. I think the most important thing they need to know is that you can't rely on a primary care provider to make a differential diagnosis of these less common forms of dementia. The primary care doctor is going to be great at saying, yes, I see cognitive change, and yes, it might look like Alzheimer's disease. But if there's anything that suggests it might not be Alzheimer's disease or it seems atypical, it's really important for those individuals to get referred to a neurologist. And from there, if even a neurologist isn't able to diagnose it, we encourage people to go to specialty clinics, like a memory disorder clinic at a teaching hospital.
I would echo that. There is also a network within, so there's a network of clinical centers that are specializing in FTD. There are also the federally funded Alzheimer's disease centers where they have the capability of doing a comprehensive evaluation with the level of detail that's necessary. We will often tell folks for FTD that if you're able to get to a place where they are diagnosing more people, where there is simply more experience seeing this type of dementia, that's where you can have the greatest confidence of getting the most current information. And I would again underscore advocacy on the part of the person with the disease and the family, so that if something doesn't make sense in what you're hearing from the general practitioner level or even a community neurologist, you may need to be the one to advocate for an additional referral if what you're experiencing and what you're hearing doesn't intuitively make sense with the additional information that's being given about the diagnosis.
Great, thank you. Another question came in asking about if there's any suggestions or specific resources available for how to develop a productive daily routine if communication becomes difficult with a person with Lewy body dementia or frontotemporal degeneration or another type of dementia. Do either of you have those kinds of resources on your website, or do you have any suggestions?
I don't know that we have a specific resource on our website that would walk people through that. I think the goal is to really have as personally tailored a routine as possible for folks. Angela, do you have a common resource that you've used?
We don't either, but my response was going to be exactly what yours was. I think it's really important to understand that each person is going to have unique likes and dislikes and unique patterns that they've lived with their whole lives. And recognizing that simplifying and maintaining a routine that's familiar to them is really what's most important, not that we're trying to fit an existing mold.
Great, thank you. There's a few questions here related to the course of Lewy body dementia and if there's a typical progression in terms of how long it might take someone to go through the process of beginning to end stages.
It's a great question. It's a very common one. Just like in Alzheimer's disease, you can have people who live a very long time with Lewy body dementia, as long as 20 years, and some people that progress extremely quickly, but that's a very, very small percentage of people where they might progress within, say, 2 years from beginning to end. In general, we say, you know, the typical person with LBD, from the time they receive their diagnosis, knowing that they've lived for several years with mild symptoms that have progressed enough for them to get to the doctor and then later to get their diagnosis, from that point we say it's about 5 to 7 years on average. But there are always people who beat the average, and certainly their quality of care, both clinically and at home, can influence that. You know, people with dementia also have other medical issues, and so the number of other medical complications that they are living with, in addition to the form of dementia they have, that can have a big impact as well.
Great, thank you. And Sharon, could you answer similarly for frontotemporal degeneration?
Sure. You know, it's interesting because the parameters that Angela outlined would be similar for FTD, in that the average life expectancy from the onset of symptoms would be 6.5 to 7 years, but there's a very wide range of 2 to 20 years. Predicting the course of the disease and helping families to know what to expect might be coming next is one of the greatest challenges that the folks working in this field are facing. It's very variable. You know, people here, if you know one person with FTD, you know one person with FTD, and part of that is that the disease is going to progress at different rates in different people and affect different cognitive symptoms along the way as it progresses. So depending on where it starts, you will develop symptoms related to some of the other cognitive functions, whether it's language or behaviors or movement, but it's very difficult to predict the rate at which that may happen and the nature of what those symptoms will be, and it's a real source of difficulty for families.
Great. Thank you so much for your responses to those questions. It does look like we have run out of time for today. I want to thank you both so much for your presentations today, and I'll turn it over to Steve Morse for some final comments.
Okay, great. Thanks, everyone. Great presentation. Yes, it is time for us to wrap up, everyone.